discussing today about the most common subject, most common common things of the for the student, both for student and doctors, and for everyone, that tonsillitis, acute and recurrent tonsillitis, Faucial diphtheria. There is nobody in the world who suffers from the sore throat or pain. Anyone, anytime sufferings from this one. And this pandemic situation, the patient may come with you sore throat, cough, or nausea, anything else, fever. So when you started in the exam, in the written and both in the viva, then first you see the questions about the tonsil. The part of the ENT is throat. This is throat. Sore throat. What is sore throat? It means inflammation of the tonsil, pharynx, or larynx, and the throat. These four divided four things. The ENT subject, that is throat, nose, ear, and head and neck. So it is the first and basic subject, basic one of ENT, that is tonsil. So I go to the second slide. What is the second slide? Introduction. You know that the tonsils are so many tonsils in our throat, pharynx, and throat. Excuse me. Okay. The palatine tonsil is the twin number. This is most important. The oral cavity, the throat is divided into oral cavity, pharynx, and larynx. In this part, there is in the palatine tonsil is most important, and there is a Walder's ring of 4 types of tonsils in the oral cavity, pharynx, nasopharynx, and lingual, and the tubal. There is a palatine tonsil or facial tonsils. There is a nasopharynx tonsils or adenoids, tubal tonsils, and the lingual tonsils. When you go through the tonsil, then the question is asking from the examiner, that is what are the types of tonsil, or what is the Walder's ring. These 4 types of tonsils consists of the Walder's rings. And there is also question, what is it? There are lymphoid tissue situated laterally, lateral wall of the oropharynx. The pharynx is divided into nasopharynx, oropharynx, and laryngopharynx. And the palatine tonsil is placed in the oropharynx and between the anterior and posterior pillar. Medial surface of the tonsil, it is a basic anatomy, applied anatomy of the tonsil I described. Medial surface of tonsil is covered by non-keratinized stratified squamous epithelium, which dips into the surface of tonsil in the form of crypts. Opening of crypts is 12 to 15 numbered, present on medial surface. The big one is named crypta magna or intertonsillar cleft. So you have to, there is a question from the examiner that what is the crypts and what is the number of crypts, or what is the name of the big crypts, that is crypta magna. This is applied anatomy and normal, and there is a general question to the every student. Crypts may be filled with sticky materials consisting of epithelial cells, bacteria, and food debris, which is expressed by pressure over the anterior pillars. Crypts, there is a sticky material consisting of epithelial cells, bacteria, food debris, which is expressed by pressure over the anterior pillar. When you pressure on anterior pillar, there is a few material, CZ material, that is a solid, semi-solid materials coming through the crypts. This is consists of epithelial cells, bacteria, food debris. Lateral cells of tonsil present as well-defined fibrous capsule. This is fibrous capsule is important for the surgeon, that when the surgeon going to the tonsillectomy or tonsil operation, he should detected the fibrous capsule, and we dissected through the fibrous capsule. Between the capsule and the bed of the tonsil is the loose alveolar tissue, which makes it easy to dissect the tonsil in the plane during tonsillectomy. It is the site of peritonsillar abscess. Peritonsillar abscess is another lecture, so I do not describe it here. So bed of the tonsil, it is most important, is formed by superior constituent styloglossus muscle. You have to question that there is a, what is the formed by bed of the tonsil? This superior constrictor and styloglossus muscles. The glossopharyngeal nerve. Important relation of tonsil is glossopharyngeal nerve and styloid process. During in relation to the lower part of the tonsillar fossa, lower part of the tonsillar fossa. So it is another question. What is the important structure related to tonsillar fossa? Outside the superior constituent, tonsil is related to, what is the relation? Facial artery, most important artery, submandibular salivary gland, posterior belly of digestive muscle, medial pterygoid muscle, and angle of the mandible. So this is the applied anatomy of the tonsil. When you go to surgery, you should know the relation, minimum relation of this, and you have a question: what is the relation of tonsillar bed? So there is a outside, you know that superior constrictor muscle, that is the facial artery, most important, submandibular salivary gland, posterior belly of digestive muscle, medial pterygoid muscle, and the angle of the mandible. So what is the physiology? Physiology is main function of tonsil is providing local immunity. Providing local immunity and providing a surveillance mechanism, so the entire body is prepared for defense. It is important. Main function of tonsil is providing local immunity, providing a surveillance mechanism, so then entire body is prepared for defense. There is another question frequently you face. That is difference between tonsils and lymph node. What is tonsils and what is lymph node? Tonsil is a subepithelial collection of lymphoid tissue. Subepithelial collection of lymphoid tissue, but lymph node is subcutaneously present in the confluent of the lymphatic vessel, small masses of lymph tissue. But tonsil is a large mass of lymphoid tissue. Tonsil is partly encapsulated. The medial surface is not encapsulated, but lymph node is fully encapsulated. Hello, my dear student. Do you hear me? Hello.
Yes, sir.
Hello.
Yes, sir.
Hello.
Yes, sir.
Yes, sir.
Do you hear me? Please
Yes, sir.
respond. Why not? Why you are stopping silently? Because there is a some interaction with you, everyone, and then the lecture is a fruitful. Now it is a important question. There is a difference between tonsil and lymph node. If there is a you see question, written question, and also in the viva, you are facing this. So tonsil has efferent vessels only. Efferent means away from the center, and the lymph node has afferent and efferent vessels. Tonsils, it's present in the tonsil, but lymph node has no clips. Tonsil has no cortex and medulla, but lymph node has a cortex and medulla. Growth are present in the tonsil, but in lymph node absent. So, difference between tonsil and lymph node. In every student facing this question, that what is the difference between tonsils and lymph node? So next one, acute tonsillitis. Now we have to acute tonsillitis, itis. What is itis? What is the acute inflammation? You know the in the pathology of tonsil, acute tonsillitis. You already completed pathology, and you know the definition of the acute inflammation. There is a 5 things: rubor, pallor, dolor, tumor, or functional loss. This is the 5 component of acute inflammation. So, acute inflammation of the tonsil is the inflammation of surface epithelium, crypts, and lymphoid tissue of tonsil. Is known as acute tonsillitis. So, when a patient come to you, they have a fever, they have a pain, they have a dysphagia, and they have a loss of some function, and the tonsil is enlarged. So all the features of acute inflammation is present. Basic symptoms present in the acute inflammation. Though you are no acute appendicitis, acute laryngitis, acute pharyngitis, and all the acute inflammation present with you, the patient has a fever, and there is a painful condition, cramps, and there is a loss of function, there is a dysphagia and other things. So what is the classified acute tonsillitis classification? There is a classification is not important, but everybody should know, because some teachers may question you that what is follicular tonsillitis, what is another type of tonsillitis, that is parenchymatous tonsillitis or membranous tonsillitis. So you should have answer. So you should know the acute follicular tonsillitis, an infection spread into the crypts, which become filled with purulent materials and presents on tonsil surface as a bluish spots. Purulent materials, that means pus-like things. Pus is present on the tonsillar crypts like bluish spots. So acute follicular tonsillitis, there is a picture. This is the feature of acute tonsillitis. You see that the tonsil is enlarged. There is a small spotted, whitish spotted on the tonsil, and there is a swelling of the tonsil, and the patient is come to you with the features of acute inflammation. Acute inflammation. I go it. I describe afterwards. There is a slide about it. So, acute parenchymatous tonsillitis. What is acute? Here the tonsils are uniformly enlarged and red. Uniformly enlarged and red. This is one of the feature. You see, there is a ventricular is congested, tonsil is congested and red. The uvula is also red and congested, and there is a pharynx is posterior pharyngeal wall is also red. So acute membranous tonsillitis, it is most important. It is most important because in this stage, exudation from the acute scroll to form a membrane on the surface of the tonsil, which is followed by acute follicular tonsillitis. We see that in acute follicular tonsillitis, there is a spotted appearance. But in the acute membranous tonsillitis, there is a whitish covering whole over the tonsil. That is acute membranous tonsillitis. And it is important that Faucial diphtheria, between the Faucial diphtheria and acute membranous tonsillitis, how can you differ? We have discussed it this lecture, and there is another slide that I described. Okay, this is acute membranous tonsillitis. You see, whole tonsil is covered with whitish membrane. Etiology, yes, etiology, it is most important. Etiology is most important that children are more affected than adults. You see more patients come to you, the parents come to you with acute tonsillitis of the children. Most commonly bacteria is Streptococcus hemolyticus. Group A beta hemolytic Streptococcus. It is the important question to you that in Viva, the examiner you asked, what is the common bacteria? So you should answer. This is basic. This is basic. Basic to you should have to answer this one. Streptococcus beta, group A beta hemolytic Streptococcus. Other organisms are Staphylococcus aureus, pneumococcus, and Haemophilus influenza. So you know the bacteriology of the tonsil. This bacteria may be primary infection of the tonsil or maybe secondary to viral infection. There is so many viral infection. Now there is a SARS COVID-19, you know, the pandemic of the world. This viral infection causes sore throat, cough, and other things. So it may be by secondary to viral infection. This is important. What is the clinical features? Clinical features includes symptoms and signs. When a patient come to you, what is the complaint? You listen the complaint of the patient. What is the chief complaints? When you written the history, then you should know about the symptoms of the tonsil. What is the first thing? Sore throat. Sore throat is a term, is a common term, but what is the important is the painful condition of the tonsil, pharynx, and larynx. It is the inflammation, acute inflammation of the pharynx, tonsil, larynx, and pharynx. So second thing is difficulty in swallowing. This is dysphagia. Patient always said about their language, but you should know the medical term that is difficult in swallowing dysphagia. Fever, high fever, it may vary from 102 degrees Fahrenheit to 103 degrees Fahrenheit with chills and rigor. There is a referred otalgia. Acute otitis media may occur as a complications. Referred otalgia means there is a same nerve supplying in the tonsil and also in the ear. So there is a glossopharyngeal nerve, vagus nerve. It is a same supply to the throat and tonsil and the ear. So there is some patient come to you earache. Acute otitis media may occur as a complication. So the through eustachian tube, the virus bacteria may go to the medial layer and the patient may present with you acute otitis media. Constitutional symptoms. There is a generalized symptoms: headache, bradycardia, malaise, and constipation. There is a malaise, body ache, headache, and also constipation. Why? Because there is a generalized lymphadenopathy when acute tonsillitis is present. Patient may present with acute appendicitis also because there is so many lymph nodes. So generalized when tonsillitis start, there is a generalized lymphadenitis through whole body. The tongue is furred. There is a white coated on the tongue. Breath is fetid, foul smelling breath. Ventricular, subpilar, uvula congested, tonsillar red and swollen. Uvular spot or purulent materials present on clips in acute follicular tonsillitis. We have described it. What is membrane on the medial surface of the tonsil easily removed with a swab in acute membranous tonsillitis. The tonsil may be hugely enlarged and congested as much as they almost meet in midline, causing obstruction of foot passage and airway in acute parenchymatous tonsillitis. Sometimes when two tonsils is near, it is called kissing tonsils. Acute parenchymatous tonsil, other name is kissing tonsils. Two tonsils are close, and the airway and foot passage also obstructed. Jugular-gastric lymph node enlarged and tender. Jugular-gastric lymph node is a draining lymph node of the tonsil is jugulo-digestive node. Where present? It is present half inch below and behind the angle of the ventricle. Half inch behind and below of the angle of ventricle. Treatment. It is important. You saw what is the important bed rest. It is a bed rest, ensure normal diet and plenty of water. Plenty of water. Patient is a high temperature, may patient suffer from dehydration, so plenty of water should take and normal diet. Analgesic antipyretic. And when you tell about the treatment, you should complete about the generic name of the drugs and not companion. That is paracetamol, 500 ml or 1 to 2 tablet daily, or back-to-back suppository. There is a 12.5 millimeter, 12.5 millimeter, and 50 millimeter. One stick per rectal when patient complains of high fever and pains. Antibacterial therapy. Penicillin is the drug of choice for streptococcal infection. Other available antibiotics are ciprofloxacin and cefixime for 7 to 10 days. You should mention about the antimicrobial drug. Name of the antimicrobial drug. Antihistamine. There is so many antihistamine. There is when tonsil is infected, there is a secretion. Secretion is coming out from salivary glands and other mucous glands. So you should compromise it. So antihistamine, that is chlorpheniramine and maleate, cetirizine, levocetirizine, rupatidine, ivastatin, which decrease the nasal, oral secretion and cold effect. And H2 blocker, ranitidine or omeprazole if used analgesic. When we give analgesic, that is back-to-back suppository, we routinely give them H2 blocker. There is a ranitidine and omeprazole. Complications. Most important question. If there, what is the complication of tonsillitis? Chronic tonsillitis with recurrent attack of acute tonsillitis.
Sir,
This
Assalamualaikum,
may
sir.
be chronicity. There is a chronic tonsillitis. Peritonsillar abscess, parapharyngeal abscess, neck abscess due to suppression of jugular lymph node, acute otitis media, recurrent attack due to tonsil. There is recurrent acute otitis media, and rheumatic fever, associated with group A beta hemolytic streptococcus, acute glomerulonephritis. The streptococcus is important cause of acute glomerulonephritis and subacute bacterial endocarditis. Acute tonsillitis with valvular heart disease may be caused by due to streptococcus viridans infection. So subacute and the complication is important. There is a 8 complication, but there is minimum 5 complications of acute tonsillitis should answer in the viva or in the written question. There is a picture, you see that there is a unilateral enlargement of the tonsil. It is normal, but sometimes there is a unilateral enlargement of the tonsil and causes there is a peritonsillar abscess and in the carcinoma of the tonsil. It is the redness, unilateral enlargement. There is a uvula is pushed is opposite side. It is acute. It is a peritonsillar abscess. It is a peritonsillar abscess. So peritonsillar abscess is always acute. So the term is not used acute peritonsillar abscess. It is a peritonsillar abscess. This is about the everything about tonsil. Now come to the Faucial diphtheria.
Sir, Assalamualaikum, sir.
What? Hello.
Yes, sir.
Do you hear me?
Yes, sir. Sir, একটা প্রশ্ন ছিল
Follow the slide.
স্যার, একটা প্রশ্ন ছিল স্যার।
Faucial diphtheria. What is the important? Faucial diphtheria. It is etiology is you know about diphtheria about in the infant. In the infant, when children are born, there is a schedule of immunization schedule in Bangladesh and everywhere. But immunization schedule there is a DPT, diphtheria, pertussis, and tetanus. There is a immunization schedule. So there is a now diphtheria is not common, but you should know about it. You should know about it. Faucial diphtheria, most important. Etiology, gram-positive bacteria, name Corynebacterium diphtheria. Caused by gram-positive bacteria, name Corynebacterium diphtheria. It is spread by droplet infection. Droplet infection. There is a sneezing. There is a coughing. Then there is a droplet. And when one patient, diphtheria patient, is contact with another normal patient, there is a suffering from diphtheria. Incubation period. It is 2 to 6 days. Some personal carrier of this disease, they harbor organism in throat but have no symptoms. All the so many person carrier of the disease, and they harbor the organism Corynebacterium diphtheria, and but no symptoms. Clinical features. Children are affected more. Children. So we have immunization. So now the diphtheria is uncommon. Oropharynx is commonly involved. The larynx and nasal cavity also be affected. Oropharynx. We know pharynx is divided into three parts, and one part of lower pharynx. And the larynx, when larynx is involved, and also nasal cavity also. When larynx involved, the patient is in grave condition. So it is important. If the laryngeal diphtheria is a patient developed, there is a maybe respiratory obstruction. Patient come to you respiratory obstruction. So with tracheostomy, sometimes tracheostomy may be done. We describe it afterwards, tracheostomy. So sign, clinical features, sign, what you see, what you see. Pharynx show a grayish white membrane forms over the tonsil and spreads to the subplate and posterior pharyngeal wall. Oropharynx shows a grayish white membrane forms over the tonsils and spread to the soft palate and posterior pharyngeal wall. But in acute membranous tonsillitis, this membranes, white membranes, is only over the tonsils, not soft palate of posterior pharyngeal wall. In diphtheria, it is firmly, the membrane is firmly adherent to the overlying mucosa, causing bleeding when attempting to remove. It is firmly adherent in diphtheria, overlying the mucosa, causing bleeding when attempting to remove. But in case of acute tonsillitis, the membrane is softly adherent and you can easily remove it, and there is no bleeding. But in diphtheria, it is firmly adherent. So there is a bleeding when attempting to remove. Cervical lymph nodes, particularly the jugular lymph nodes, become enlarged and tender, and sometimes presents a bull neck appearance. Bull neck appearance. Bull means ষাঁড়ের ঘাড়। ষাঁড়ের ঘাড় দেখছো যে কোরবানি ঈদের সময় তো প্রচুর গরু ওঠে, অনেক দামি দামি অনেক ষাঁড় ওঠে, তাদের যে নেক চমৎকার দেখা যায়, bull neck. So diphtheric patient presents with a jugular lymph node like that bull neck. Patient is ill and toxic, but fever is not rise above 100 degrees Fahrenheit. It is most important. Patient looking so much ill and toxic, but when you going to temperature, then is only not above 100 degrees Fahrenheit. But in acute tonsillitis, there is a fever is above 100 to 1 and 2, sometimes 103 degrees Fahrenheit. So difference between Faucial diphtheria and acute tonsillitis is important. And this is the one figure, that is the diphtheric picture of a patient. You see that there is a whitish membrane spread over the uvula anterior and the soft palate, over the soft palate, over the tonsil, over the uvula, over the soft palate. And this is a feel so adherent. And this is another picture of the diphtheric patient. Another picture of the diphtheric patient. You see that is a membrane over the uvula, tonsil, and completely obstructed the, compromised the airway and also of the food passes. complications. What is the most important complications? The diphtheria, corynebacterium diphtheria produce exotoxin. Exotoxin is toxic to the heart and nerves. Corynebacterium diphtheria producing exotoxin. It is toxic to the heart and nerves. It causes, what is it causes? Myocarditis, cardiac arrhythmia, and acute circulatory failure. So it is a important cause of sometimes death of the patient. Neurological complications usually appear a few weeks after infection and include paralysis of soft palate, diaphragm, and ocular muscles. Paralysis of the soft plate and most important, you see a diaphragm. When paralysis of the diaphragm, the patient is suffering from respiratory distress, and sometimes patient may die. In the larynx, diphtheria membrane may cause airway obstruction, maybe needed tachystomy. So when patient suffer from laryngeal diphtheria, membrane may cause airway obstruction and maybe needed tachystomy. There is a question about the diphtheria that laryngeal diphtheria, when you need tachystomy. When patient present with laryngeal diphtheria and stridor, then you should tachystomize. There is a picture. One is Faucial diphtheria. You see, it is a Faucial diphtheria membrane about the tonsil, and also about the this figure. This picture is not. You see the picture. Hello. Hello, my dear friend.
Yes, sir.
You follow me? You
Yes, sir.
follow? Hello.
Yes, sir.
Okay, thank you. Yes, there is a bull-neck appearance. This is bull-neck appearance. You see that the girl, the small girl, is suffering from diphtheria. There is a neck, jugularistic lymph node, like bull-neck appearance. This is a bull-neck appearance. Septic. One patient suffer from the toxic exotoxin secreted from the corynebacterium diphtheria, and patient comes to you with a high complication of the diphtheria. Then you see that type of patient, the bull neck appearance. There is another picture. There is another picture. Suffering from adult. It is a jugularistic lymph node is enlarged. There is a mandible, half and below the half inch below and behind the angle of the mandible, the jugularistic lymph node. But the neck is appearance is bull neck appearance. So yes, this is a picture you should see first. Then now treatment. Now treatment. What is the aim of the treatment? Because the complication arising from exotoxin released by corynebacterium diphtheria. So first we neutralize the free exotoxin, and second one is to kill the organism. So what is the treatment? Treatment of diphtheria is started on clinical suspension without waiting the culture report. We see that there is a most important neurological and cardiac complications by diphtheria. So when oral swab sent for or membrane sent for culture, we should not wait. We should not wait for the starting treatment. We are starting the treatment. Dose of antitoxin is based on the site involved and the duration and severity of disease. dose of endotoxin is based on the site. We know that there is a tonsil, there is a larynx, there is a pharynx. Different site is involved. So we know this site, we see this site, duration and severity of the disease. Number one, it is 20,000 to 40,000 units for diphtheria is less than 48 hours, or when the membrane is confined to the tonsil only. Antitoxin, 20,000 to 40,000 units for diphtheria, less than 48 hours. And membrane is confined to the tonsil only. And secondly, when the disease has lasted longer than 48 hours, the membrane spread from tonsil to pharynx and larynx, the dose is 80,000 to 120,000 units. So it is important when you give the how the unit of antitoxin, dose of antitoxin, you should depend on you. How can you time and the spread of the diphtheric membrane, Antitoxin given in saline. It is important that antitoxin is so many reaction. There is a drug, antitoxin drug reaction, so many drug reaction. So antitoxin is given in saline with the duration about 60 minutes. There is a dextrose saline or 5% dextrose saline or 5% DNS, dextrose normal saline. You give it the antitoxin about 60 minutes, 1 hour time. So you give the antitoxin in the saline, and you take the cannula, IV cannula, or anything else, butterfly needle, to give the antitoxin. Setup of the given antitoxin. Sensitivity to horse serum should be tested by conjunctival or intracutaneous with dilated antitoxin, and adrenaline should be at hand. Oh yes, we tested sensitivity. We keep a small portion, dilated portion, to the intracutaneous. Then we see if there is any drug reaction, then it is the skin is indurated. There is a red, and patient is reaction, suppressive reaction. So we manage if there is any reaction, then we adrenaline. When we give the antitoxin, all drugs like adrenaline and other drugs, Roxadex, that means dexamethasone, should in hand. If hypersensitivity reaction, desensitization should be done. Desensitization should be done. It is done by small doses. First give small, then increase the dose. When you give in saline, you give first time 2-3 drops, then increase the drops 10 or 15. And there is a bacterial infection. So antibiotic used, we use the benzene penicillin 600 milligrams 6 hours for 7 days. Benzene penicillin is there is a company name is there is a PenB, another is everything. Erythromycin. If penicillin sensitive, so we use erythromycin 500 milligrams 6 hourly orally. So So it is today lecture on this acute tonsillitis and recurrent tonsillitis and Faucial Diphtheria. When you say about the recurrent tonsillitis, recurrent tonsillitis is when the patient suffers from acute tonsillitis, repeated acute tonsillitis 3 to 4 times per year, consecutive 2 to 3 years. It is recurrent tonsillitis. When patient suffers from recurrent tonsillitis, the treatment is tonsillectomy. Treatment is tonsillectomy. So I think this is complete the lectures. And recurrent tonsillitis you should know, because there is one indication of recurrent tonsillitis, and the time should be mentioned. That is recurrent attack of acute tonsillitis 3 to 4 times per year, consecutive 2 to 3 years. And I think I have completed my today lectures. My dear students, have you any questions? Please. Hello. Hello.
স্যার আসসালামু আলাইকুম।
Yes.
স্যার যে প্যারানাসাল সাইনাসের যদি এক্স-রে করা হয় তাহলে কি আমরা স্যার বুঝতে পারবো যে
Yes.
অ্যাডিনয়েডটা, স্যার প্যারানাসাল সাইনাসের এক্স-রে করে কি আমরা বুঝতে পারবো যে অ্যাডিনয়েড এটা কি বড় হয়েছে কিনা?
Oh, you should I do not understand, because I hear it's I do not hear your question. Please again.
হ্যালো
Yes. Hello. Yes, again, please.
স্যার মানে আমার, জি স্যার, আমার হচ্ছে বোনের মেয়ে, ওনার হচ্ছে 9 বছর, তো
Yes,
ওনার
yes,
কানের
yes.
প্রবলেম ছিল,
হ্যাঁ,
তো ডক্টর
তা-
2 মাসের মতো ট্রিটমেন্ট, কানের প্রবলেমটা ভালো হয় না। সে
আচ্ছা, আচ্ছা।
স্যার প্যারানাসাল সাইনাসের এক্স-রেটা করতে দেওয়া হয়, তখন বললো যে অ্যাডিনয়েডটা নাকি বড় হয়েছে স্যার।
ও,
তো এটা জানতে
আচ্ছা,
চাচ্ছিলাম
আচ্ছা।
যে প্যারানাসাল সাইনাসের এক্স-রে করে কি
Nasal sinus
এটা
তো
বোঝা যায়
আসলে
যে
আমরা
অ্যাডিনয়েডটা কতটুকু?
না, আমরা যেটা করি এক্স-রে নাসোফ্যারিংস ল্যাটারাল ভিউ,
জি স্যার।
X-ray nasopharynx lateral view in open mouth, then we diagnose the adenoids.
জি স্যার।
Tonsil, when there is a attack of recurrent tonsillitis, I said that there is a Walder's ring. There is another important tonsil is adenoids, adenoid or adenoids. It is the important cause of recurrent attack of acute otitis media, recurrent acute otitis media, and persistence of chronic otitis media. So the baby should be adenotonsillectomy. If adenotonsillectomy, adenoid is most important. Adenoid is most important for children. When adenoid is an indication of there is some complication, or a patient is suffering from snoring, sleep apnea, and the other respiratory problem. You must do the adenotonsillectomy. The treatment is adenotonsillectomy. There is no other alternative. There is a adenoid.
জি স্যার, কিন্তু পেশেন্ট,
হ্যাঁ, পেশেন্ট বলো। পেশেন্ট কি?
জি স্যার, কিন্তু পেশেন্টের টনসিলাইটিসের যে সিমটমস গুলো, ওগুলোর কিছুই নাই, যেমন গলা ব্যথা অথবা খাবার গিলতে সমস্যা হওয়া অথবা জ্বর, ম্যালাইস, এগুলো কিছুই নাই স্যার। টনসিলাইটিসের কোনো ফিচারই নাই, শুধু ছিল কানে সমস্যা।
I told you that acute tonsillitis may present with acute appendicitis. Acute tonsillitis may present with acute otitis media. I already said the patient is suffering from acute tonsillitis. Some patient is present to the surgeon with acute appendicitis. So the appendicectomy has already done, but patient afterwards come to us with throat pain and other complication. When you see there is a children without any sign symptoms of acute tonsillitis, but he or she is suffering from recurrent acute otitis media, then we go for nasopharynx, X-ray of nasopharynx to see the adenoid, where adenoid is enlarged. And we ask the patient, attendant, mothers or fathers, parents, why is he or she snoring at night? And every 90% patient is said that they are suffering from snoring. তারা মুখ হাক করে শ্বাস নেয় এবং শব্দ করে, অনেক সময় শব্দের জন্য বাবা মা ঘুমাতে পারে না। তুমি তোমার পেশেন্টের তোমার যে রিলেটিভ আছে ওর মা যার সাথে ঘুমায় তাকে জিজ্ঞেস করবে
স্যার এই সিম্পটমসও নাই স্যার, আমার সাথে এই সিম্পটমসও নাই যে আগ দিয়ে শ্বাস নেয় অথবা হাক করে ঘুমায়।
হ্যাঁ, এটা সিম্পটমস না থাকলে যদি adenoid, if adenoid, mild adenoid, no symptoms, but modern adenoid symptoms produce 90% symptoms, but severe adenoid, that is compromised airway, there is so many symptoms. If there is no symptoms but X-ray suggests that there is a moderate enlargement of the adenoid, so you should go for surgery. There is no alternative, because if there is a recurrent acute otitis media, then there is a perforation and there is a chronic otitis media. The patient is suffering from chronic otitis media. So you understand me?
জি স্যার, তাহলে অ্যাডিনয়েডেক্টমি আর টনসিলেক্টমি দুইটাই করতে হবে?
Yes, because when we go adenectomy, there is then tonsillectomy also done. Because one, if you are done, then the tonsil is enlarged, and there is some symptoms, sign and symptoms produced that like dysphagia and sore throat, throat pain. So we at the same time we done adenotonsillectomy and tonsillectomy, adenotonsillectomy. In the Bhagavasi, always your teacher questions that if the patient had adenoid, when you do adenectomy singly, but not tonsil, but you should answer we should done the adenotonsillectomy. We question the student, and you face in your practical life. In practical life, there is so many doctors, patient, doctor children who will come to us with adenoid. We advise their adenectomy, but they are delayed. Delayed adenectomy is patient there is so many complications. When we go through adenectomy and tonsillectomy, then we describe everything. And this is, everybody know that when one children patient come to you with throat pain, and you see acute tonsillitis, below 3 to 10 years, you must do nasopharynx, X-ray nasopharynx laterally to see the adenoid. When you are a doctor, you will see so many children patients and come to you with pain throat, cough, and other things. But you should done one thing, that is nasopharynx, X-ray nasopharynx. adenoid is tonsil and adenoid is cause of so many complications. You know that there is so many kidney patient, acute glomerulonephritis. There is so many patient. There is a kidney patient, and there is a patient CSOM, chronic otitis media, and these patients are suffering from in children from adenoids. And there is a adenoid facies, high prominent incision teeth. You see, there is so many person is there is a prominent incision teeth. They are suffering from children adenoids with adenoids. Obligate when adenoids close the nose, there is a obligatory mouth breathing, and there is overguarding of teeth, prominent incision teeth. You know, the higher palate, and they also suffering from deviated nasal symptom, hypertrophic intervals, and frequent infection, rhinitis, rhinosinusitis. So today there is a time is completed. Okay.
Thank you so much, sir.
Okay, welcome. We see you later. Okay, thank you everybody for patient sharing. Thank you.